Nursing is hard and meaningful, and sometimes you just need to hear from someone who's walked in your shoes. Voices in Nursing is a podcast that's here to support you with real talk, leadership insight, and stories that speak to the heart of our profession. So no matter where you are in your career, a new grad, a charge nurse, or the CNO, this podcast is for you. There's something powerful about hearing the stories of other nurses. Those real moments shared by my peers and mentors have shaped the nurse that I am today. So check out Voices in Nursing podcast for yourself. I've put a link in the show notes for you.
We are very concerned with noxious stimuli. So if you are starting that IV, if you are agitating this 10-year-old further, you might see where the tipping point of this diagnosis shows its true colors of a full pulmonary hypertension crisis event. You could jack up that PVR so much that RV, there's no flow forward, which means there's no flow on your left side, which means you could have either a syncope event or leading to an arrest with a pulmonary hypertension crisis.
Wow. So what I'm hearing you say is the way that you conduct yourself as a bedside nurse and how you help coordinate the care of the team could impact this patient's outcome. If you come in guns a-blazing, scaring this kid, or lots of people rushing at one time, you don't use any measures to keep them calm, you actually could make things worse and cause this kid to even arrest possibly if they're so clamped down, so freaking out. Yeah.
Absolutely. You nailed it right on the head.
Hey there. I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Welcome back to the Rapid Response RN podcast. I'm Sarah Lorenzini, and today I'm joined once again by my friend and fellow podcast host, Natalie. So good to have you back on the show.
Thank you for the invitation, Sarah. It's always a privilege to work with you.
Yes. So for those of you that have not heard it yet, I actually had Natalie on my show back in August on congenital heart disease. She is a pediatric cardiac ICU nurse and is helping me freshen up on all things pediatric cardiac emergencies. So today we're tackling two fairly common presentations to the ER by breaking down two separate cases of two different kids, but same age, same symptoms, two very different diagnoses, which is pulmonary hypertension and dilated cardiomyopathy. Like, these kids can look almost identical when they roll into the ER, shortness of breath, fatigue, tachycardia, low oxygen saturation. But as we dig into their stories, like their history, their exam, their diagnostic findings, the puzzle pieces kind of fall in place. So treatment strategies, yeah, you guessed it, also very different. So let's walk through two cases side by side, tease out the differences, and break down the pathophysiology and management of each. So pediatric cardiac expert in the room, take it away with our two patients.
Okay, so our first patient is going to be Penny Pressure, and our second patient is going to be Casey Cardio. Love the names. Great.
Love the names. Embrace the cheesiness if it helps us remember the two cases. All right, tell me about Penny Pressure.
Okay, so Penny Pressure is a 10-year-old female with no significant past medical history. So she's going to come into the ED. She's complaining of fatigue, worsening shortness of breath, dizziness with exertion, and actually was brought in today for an episode of syncope. Her parents found her and had to bring her in for this. Next patient is going to be Casey Cardio. And so this is a 10-year-old female coming into the ED with no significant past medical history, similar symptoms, fatigue, dizziness with exertion, and now worsening shortness of breath with some nausea.
Okay. Very, very similar presentations. Okay. if you are receiving these patients, what kinds of data would you want to have to help you figure out which diagnostic and treatment path we're going to go down?
So thinking of both these presentations, the big difference I'm noticing in the family history or the parent reporting to me off is the syncope event for these patients. Because they both have some sort of hypoxia, they both have some sort of fatigue, shortness of breath, but that syncope event is very kind of red flags me as a bedside nurse to think, okay, dilated cardiomyopathy, they don't really pass out. What could be, the question I'm asking here is, why did this patient have a brief reduction or lack of blood flow to the brain that would make them pass out?
Okay, gotcha. How do the vital signs compare and differ in these two presentations?
Vital signs are actually pretty similar. So you're going to have tachycardia, heart rate's in the 130s. For a 10-year-old, normal is less than 100 for a heart rate or around that range. The blood pressures might see 80s over 40s, a little bit on the hypotensive side, because normals for a 10-year-old would be 90 to 110 systolics. Your respirations might be in the 30s for both of these presentations, knowing that a normal is around that 20 mark. So you're having some tachypnea. The oxygen saturations are going to be less than the norm. They might be in the high 80s, low 90s, and they're going to have that, the complaint of, I just feel like I can't catch my breath. I feel like I can't breathe. They'll be on room air with those saturations. And both these patients, they might not have fevers.
Okay. So both presentations are going to have this tachypnea, shortness of breath, can't catch my breath, a little hypotension, but for very different reasons. As you dig in further and pull the covers back and bust out your stethoscope, what are you finding on each patient?
Right. Great question. So as you are clinically assessing them as the bedside nurse, you're going to be listening to their lung sounds. I think that's one of the first things you do with your stethoscope. And you might notice that in this pulmonary hypertension kiddo, they might not have a wetness, coarse, crackly sound to their lungs. If you are listening to this dilated cardiomyopathy, you're going to notice the crackles, the wetness, and then that x-ray machine is going to come in. You're going to snap a picture of their lungs. And guess what? Those are going to be, kind of leading you down to differential diagnosis paths with the findings of the x-ray.
Gotcha. Okay. All right. So I think this is a good spot to back it up and do a little history on the patho for each one, because I think that that's going to help us understand more, wrap our heads around the diagnostics and what to expect as far as the findings when we start getting pictures of this kid, from x-rays to EKGs to, all the different things. So back to penny pressure. We know, because we already know the diagnosis. We're not ER nurses. We're now ICU nurses that have that information, that intel. For penny pressure, she has pulmonary hypertension. What would cause pulmonary hypertension in a kid, and what actually is happening inside the pulmonary vasculature? And how does that affect everything else in her body?
Very great question. So pulmonary hypertension, I know it has a bunch of different groupings of how you can develop this. But basically what it means is that you have very high pressures in your lungs. So you have a high PVR, a high pulmonary vascular resistance. For some reason, your arteries or those vessels are thickened, narrowed. They are creating high pressures in your lungs. That means that the RV is struggling or has to work harder to push blood forward to the lungs. And it should be on the right side, a low pressure system. But this pulmonary hypertension is creating it a high pressure system. So the RV is having a difficult time pushing blood forward to your lungs to oxygenate.
Gotcha. So tight vasculature for whatever reason inside the lungs means the right side of the heart has to work so much harder to push that blood through it, which results in right heart failure. Okay, good. On the flip side, patients who have left-sided heart failure from dilated cardiomyopathy, so the left side is stretched out and dilated, can't pump effectively, what would be the cause of that?
So when I think of dilated cardiomyopathy, I'm thinking shock. This patient has a left ventricle that the function is bad, and that function could be, in this particular diagnosis, the function is bad because you have such a large LV. The best way I can describe this is, the provider actually taught me this at bedside, is think of it like a rubber band, okay? So you have, in a normal heart, the ventricle stretches with increased volume or preload, and then there's going to be an increased contraction of the ventricle leading to increased cardiac output. So in a failing heart, giving volume increases the left ventricle end diastolic pressure. So you're stretching it out further of the ventricle, and that LV can't generate enough contractility to even empty the ventricle in the beginning. And so with a worn out rubber band versus a new rubber band, you're going to be able to, with the new one, it coils back completely after being stretched, normal heart. With a used or worn out rubber band, it's not going to coil back completely. And this leads to a stasis of increased volume in that left ventricle. And that left ventricle is already failing to eject what it has in it. And so that's just going to sit there, and then it's going to backflow into the lungs.
Good. I want to add to your analogy, hair ties. I'm sure all you people listening with long hair know the struggle when you have a hair tie that's just been overstretched, and that nice tight hair tie that used to recoil back and hold your hair in place. Well, now that thing is overstretched and floppy, and it is not going to hold your hair. It is time to get a new one. For hair ties, there's no repair. For dilated cardiomyopathy, we have medications for that. But it's just as far as the visual goes, think about a nice, tight, brand new hair tie. It holds your hair really good. You stretch it out, it recoils back. But once you overstretch it, it ain't going back. It's never going back to its original size. Okay, continue.
That was amazing. I stick with clips now. I stick with clips. So that is, I would say those are the two kind of pathophysics for the pulmonary hypertension and the dilated cardiomyopathy. Your function could be fine. Your LV function could be fine in pulmonary hypertension. Your function is not fine in dilated cardiomyopathy.
Okay. So then that causes more problems, right? If you can't mobilize the blood out of the left side of the heart, where does it back up?
Right. Backs up into their next door neighbor, the lungs.
Next door neighbor.
And so what you're going to see is the blood volume, you're drowning. That's basically what the lungs are. You're wet, you can't breathe, they have this dry cough, and they just can't catch their breath because you're flooding the lungs with all of that backflow pressure. Your LA pressures are going to be extremely high, and it's just going to keep going back into your lungs. So that X-ray that we talked about, it's going to be whited out because you're going to have pulmonary congestion.
Okay, good. All right, so just to review, both kids are 10 years old. They both come in with worsening shortness of breath, hypoxia, hypotension, tachycardia. When you examined Penny, what was different than when you examined Casey cardio?
So when I examined Penny pressure, I'm listening to the lungs, not noticing the wetness. I'm listening to the heart. I hear, a very fast heartbeat. I'm checking for pulses. We might not have thready, weak pulses. They might be okay. I'm looking at her lips, her, nail beds, all those things that might show me some sort of discoloring, some hypoxia. I'm watching how fast she's breathing. And the, palpation on the liver is something that we'll do in the ICU because that'll be huge for right-sided, left-sided heart failure. So I'm palpating maybe an inflamed liver on this patient. When I go into Casey cardio, very similar presentation, except, those lungs, like we talked about, they're going to be extremely wet, but you're still going to have the tachypnea. You're still going to have that tachycardia. Pulses might be a little bit weaker, thready in those distal, because you're in shock, right? You're not getting that flow out the left side of your body. So the cap refill on your lowers might be a little bit lengthier. The pulses might not feel as great.
Okay, very good. So just to differentiate, even before we have diagnostic results yet, we already know Penny pressure is having symptoms of right heart failure. Her liver is enlarged. She has the shortness of breath. Yes. She had the syncope. We're having trouble moving blood forward into the lungs. With Casey cardio, we're having symptoms of left-sided heart failure. So the lungs are backing up with fluid. We have symptoms of poor perfusion to the extremities, possibly to the other vital organs, like maybe the kidneys are starting to shut down, the liver's not doing so good, the gut. So yeah, we would need some more diagnostics to confirm all of that, but we kind of have our ideas, right? We have our guesses, and then we will get diagnostics to confirm where we think this is going. So let's move on to diagnostics. So what kinds of diagnostics would you anticipate someone that comes in with shortness of breath, tachycardia, tachypnea, hypotension?
You might notice an enlarged heart, right, for Casey cardio. So you're going to be like, oh, I'm going to need to get some BNP labs, some troponin, just check out what heart, if we're having some signs of heart failure based on this enlarged heart on the X-ray. You're going to get CBC, renal, all the things, your viral studies, cultures. The one thing that I will say that we notice is in pulmonary hypertension, so in Penny pressure, if you don't see that enlarged heart on her x-ray, because you probably won't for penny pressure, we are very concerned with noxious stimuli. So if you are starting that IV with penny pressure, if you are agitating this 10-year-old further, that you might see where the tipping point of this diagnosis shows its true colors of a full pulmonary hypertension crisis event. Because if you are creating noxious stimuli by starting that IV, by putting all these stickers on, taking them off, this 10-year-old's already scared with all these people in the room, you could jack up that PVR so much that RV, there's no flow forward, which means there's no flow on your left side, which means you could have another event of no flow out of your body. So, either a syncope event or another passing out event or leading to an arrest with a pulmonary hypertension crisis.
Wow. So what I'm hearing you say is the way that you conduct yourself as a bedside nurse and how you help coordinate the care of the team could impact this patient's outcome. If you come in guns a-blazing, scaring this kid, or lots of people rushing at one time, you don't use any measures to keep them calm, you actually could make things worse and cause this kid to even arrest possibly if they're so clamped down, so freaking out. Yeah.
Absolutely. You nailed it right on the head.
Okay. So as a nurse, keeping that in mind, I'm like, all right, is there a way I could dim the lights? Can I control my cadence and my tone whenever I'm talking to this kid? Can I bring in, child life specialists to come with me before I do interventions? Like, how can I interact with the family and, coordinate with them to reduce anxiety and whatever it might be. If there's like crazy Aunt Betty in the room who's making things worse, she's got to go, like that kind of stuff. How can we optimize this kid with things that have nothing to do with the meds I'm going to give? It's all about how I show up in the room for this patient. Thank you. I just wanted to highlight that little point. Excellent. Excellent.
Absolutely.
Nurse hack right there. Okay. Penny pressure.
And Casey Cardio, they're going to be best friends after this episode.
They're next door neighbors in the ER in our hypothetical hospital. Okay. So penny pressure, you're approaching very gingerly and being aware of the risk there. Casey Cardio is going to have a very similar workup. Definitely going to have the chest x-ray, blood work, all the things, echo. What I want to know is how are we going to manage these kids differently, even in the beginning? So we see a big old left heart on Casey Cardio. What interventions are you anticipating? Hey guys, I just wanted to take a quick break to talk about something that I think is really important, and that is getting certified in your nursing specialty. Not because having the extra letters behind your name make you a better nurse, but because taking the time to deep dive into all that you need to know for your specialty, putting in the study hours, and dedicating yourself to mastering what your patients need you to know how to manage them best, the prep for the exam, is what will make you a better nurse. So whatever specialty you are currently working in, go study for that certification exam. And if you're a critical care nurse, I have something that will help you pass your CCRN. My friend Nick McGowan has an excellent online self-paced CCRN prep course called Critical Care Academy. It is so thorough, and he has broken down everything you need to know into little bite-sized digestible content that he calls micro-learning. Let me tell you, the CCRN is the hardest test I've taken in my entire life. You don't want to go it alone. You want to take this course to ensure that you know your stuff before sitting for the exam. If you'd like to check out his course, you can find it at ccrnacademy.com. And great news, just for being a Rapid Response RN podcast listener, you get 10% off the cost of the course by using the coupon code RAPID10 at checkout. So if you've ever considered getting your CCRN, do it. And let Critical Care Academy help make sure that you will pass. I'll put the link and coupon code in the show notes.
So with Casey Cardio, big left heart, lower blood pressures, tachycardic, your main goal here is to support the function, is to support the overall cardiac output hemodynamics, because you don't want your blood pressure to drop any further. And so gingerly, what we would do for hypotension is you want to give that 10 ml per kilo fluid bolus. Well, for this patient, we go back to the hair tie, the rubber band. If you're going to give that 10 ml per kilo fluid bolus, you're going to be watching your blood pressure, because you could worsen cardiac output by dilating that LV further. And so we're not only going to support with volume, but we're also going to support from a heart muscle squeeze contractility. And so you might start thinking, how can I, after I apply the oxygen, to get my oxygen saturations up and support that tachypnea? How can I increase the blood pressures? We give a fluid bolus. Well, next drug you're thinking about is what inotropes do I need to support or have at bedside or consider to support the squeeze of this heart?
Okay. So what inotropes are you used to using for this patient population?
Our lovely drug epinephrine. I carry it in my back pocket. It's in my kids' snack bags. No, I'm just kidding. No, for this patient, we would definitely use epinephrine. It's a lovely drug. It's going to help support the squeeze, the heart muscle, the contractility. We'd also use calcium chloride. Our kiddos love calcium. Your heart loves those free-stored calciums in the pediatric population. And so we would use that drip as well to help support the contractility and blood pressure.
Okay. And then as far as penny pressure, let's be honest, diagnosing pulmonary hypertension in the ER doesn't always happen. These kids often need to have a little further diagnostic besides chest x-ray and, listening to the lung. I mean, how would we ultimately come to this diagnosis for this kiddo?
So ultimately, the gold standard diagnosis for pulmonary hypertension is a cath lab. You have to be able to shoot the numbers on the right side, get a pulmonary artery pressure, and diagnose that. Using an echo would also help start thinking of, we have a dilated or a RV that is hypertrophied. It's very dilated. And, our pulmonary arteries are having higher pressures, which could help lead us into that direction or have that on our differential. Because like I said, in the echo for your pulmonary hypertension, your LV is fine. The function is okay. It's not dilated. It's your RV that's the problem. And so, yes, a cath procedure would be the ultimate diagnosis for this patient.
Okay. All right. So penny pressure is on her way to cath lab, and then we'll be coming to you in the pediatric cardiac ICU. And Casey Cardio has been started on epinephrine, and we're, stabilized the blood pressures. The kid's perking up, getting a little bit more color to them, and they're also heading to the CVICU. I guess the question for me is, never having worked pediatric cardiac ICU, what is the care like and management of this patient once they get in your hands? Like, what are your priorities as a nurse? What are you watching for? What's the worst case scenarios that you're always thinking about?
So I think of when a patient I know or a 10-year-old is coming to me with a very, very high risk of arresting. The goals of dilated cardiomyopathy are correct the hemodynamics, support the function of the heart. And in order to do that, you have to create all of this noxious stimuli, all these things that can further hinder or further lead to a cardiac arrest. And so when this patient comes to us, there probably will be about 5-10 people in the room, because what we have to do is establish, we need central access on this patient. We need to monitor a central venous pressure, and we need to give inotropic support to that LV to help it squeeze out, or we will go into a significant low cardiac output syndrome. So they're coming to us. We have our line cart right outside the room. We have a provider that's going to start an arterial line, a provider that's going to start a central line. Sometimes we even call our cardiac anesthesia ahead of time, because they're going to help intubate the patient because they're such a high risk intubation. We will probably ahead of time talk with our surgeons to say, if intubation doesn't go well and we do end up arresting, we would need to put this patient on ECMO support, or we need to think about how we can support them from a mechanical circulatory support. And so it's chaotic, but it's controlled chaotic. And we're going to get that central line placed in a perfect world, get that epi started, get the calcium chloride started. We're going to get our arterial line, get an arterial blood gas right away to check how acidotic are they. We're going to get a venous blood gas through that central line. What's their coax like? Like, what is that venous return coming back to their heart? How well oxygenated is that? From a mechanical ventilation, we're going to be intubating this patient, trying to minimize any metabolic demand we can, because we don't want to stress out any other workload of the heart. We want that LV to have nothing hard to pump against. We want to make it just like, we know it's dilated. We're going to support you in the best way that we can.
I love that approach. Like, how can I support this kid? I know they've got a stretched out dilated ventricle, but how can I support them from an oxygenation perspective, from giving them inotropes, looking at their blood vessels, making sure their blood pressure is good enough, they're getting perfusion of the vital organs. We're just supporting on all sides until either the heart can recover and restore some function, or we can get them to a transplant. Okay, so then penny pressure rolls up to you from the cath lab. We have a diagnosed very high pulmonary vascular resistance, very high PVR. What's high to you? Will you just kind of go into that a little bit? I know ER nurses, we don't even talk about PVR, but will you just kind of dive into that?
So in where I practice, the number I kind of hear is a pulmonary artery pressure of greater than 20. And so they also do a relationship between what your RV systolic or systemic pressure is in relation to your LV systemic pressure. And with pulmonary hypertension kids, you'll see that your RV systemic pressure could be equal to LV systemic or maybe even greater than.
Oh, goodness.
Mm-hmm. And so ideally, your normal patient, an RV is like a third, a quarter systemic pressure to your LV. So in these patients, that pressure is very high.
All right. So this patient has a pretty high PVR. What are your treatment options to optimize this kiddo?
Another great question. So the goals of pulmonary hypertension is you want to do anything that's going to decrease the overall PVR. And how do you do that? You are going to correct the acidosis. You're going to also minimize the metabolic demand, and you're going to throw as many pulmonary vasodilators as you can at this kid. And so immediately, easiest thing you can do, oxygen. If this patient were in the cath lab, they're probably already intubated going through that procedure. So they're going to come back to you intubated. And so we will probably be on maybe 100% FiO2 on the ventilator. In the cath lab, they might have thrown nitric on to also be that big bad pulmonary vasodilator. And with that are the arterial blood gases. You might have a pH of 7.25, 7.3. And so we are trying to give bicarb until we can get that pH normalized, because acidosis is a pulmonary vasoconstrictor. It will make your PVR worse. And so a lot of these kids, they get a lot of bicarb to help get that pH normalized.
Okay. How about sildenafil? At what point would you guys initiate that as a treatment adjunct?
There are a few different options from medications. We have inhaled, we have IV, and then we have oral PO. I honestly kind of forget the pulmonary hypertension team is so involved in this kid's care, and they dictate when we start the IV, when we start the inhaled, and they are so crucial to this patient's success that I don't know if I can speak appropriately on the timing of all of it, but they will eventually get PO sildenafil, but it's like a transition from inhaled IV. It's like this titration game for days. It's not take sildenafil and now you have a great pulmonary vasodilator.
Right. Okay, so I guess the reason why I asked that is this kid's going to be discharged home probably on sildenafil, right? I remember being a new grad and I had a peds patient on Viagra on their med list. And I was like, what in the world? Who prescribed this kid Viagra? But sildenafil is Viagra, just generic versus brand name. All right. So what else? Anything else that you want to make sure we talk about with regards to the differences between these patients, both in presentation and in treatment? Any like pearls of wisdom that you would give to a nurse who maybe doesn't see this patient population very much?
Yeah. So in penny pressure, the scariest thing we talk about, some of the scariest patients are pulmonary hypertension kids, because if you have a crisis, what we call event, they are extremely, extremely difficult to rescue. And what I mean by that is when you are increasing that PVR so high, your RV is massively dilated. What you'll see is that ventricular septum is bowing, shifting into the LV. So you have this huge RV, a very, very small chamber LV. The function's fine, but it doesn't have preload coming in. And that is where you have no cardiac output out when you have this PVR crisis moment. And so the treatment for this is what we do is it's purely SVR treatment and it's preload. And so we're actually giving volume to these patients because we want to almost force the RV to push blood out, that high PVR, to get into the LA, to dilate the LV, to push that septum back over into the RV. That's one way that we can help treat these crises, besides correcting the acidosis. The other is phenylephrine and vaso are the drugs of choice, because what we want to do is jack up their SVR so high that it's higher than the PVR. So that way that LV is dilating and it's shifting that septum over. And so when we give phenylephrine or vaso, we jack up that SVR, and for a brief moment, you have backflow in blood into the LV to dilate it, to shift the septum, and then you get that nice ejection out of the LV for cardiac output.
Okay. That's some hard science to wrap your heads around because it's like we have only so much real estate in this heart. And so if there's like way too much pressure and it's bowing way too much pressure on the right side, it's bowing to the left side is a vital component in moving blood to the rest of the body. And so if it's being squished out, we have to like overfill it, overpressurize from the back end so it fills up so we can get that cardiac output we're needing. Oh, what a complicated patient to manage, like you said. Okay. And then how about for KC cardio? Any pearls of wisdom, examples, cases you feel like are valuable to keep in our minds as we're managing a kid with a big old left ventricle? What are your priorities? What pearls would you want a nurse to know when managing that patient population?
Yeah, so when I coach at bedside, this actually example just came up my last coaching shift, and we're going through the low cardiac output scenario. And a lot of nurses think if my patient is hypotensive, I'm in a low cardiac output state. And what I challenge the nurses, just because our blood pressure is low or out of range, that doesn't necessarily mean you're in low cardiac output. Blood pressure does not indicate low cardiac output syndrome. There are a lot of other labs, tools that we can use to help get us there. Yes, a low blood pressure isn't always great, but it could be medication related. It could be other factors. It does not correlate with low cardiac output syndrome. That would be my food for thought for new grads is hypotension does not equal low cardiac output syndrome.
That's good. Yeah. So low blood pressure doesn't mean cardiac output is bad. And normal blood pressure doesn't mean the cardiac output is good. So don't get so hung up on, I fix the blood pressure with my drip. Look at your patient and their presentation to see if this inotrope that you're supporting them with is actually helping them perfuse all of their extremities and other vital organs. That's good stuff, Natalie. All right. So there you have it. 2 kids, same age, nearly identical presentations in the ER, but one has pulmonary hypertension, penny pressure, and the other has dilated cardiomyopathy, KC cardio. The only way to tell them apart is through careful history, a targeted physical exam, and diagnostic testing. And once you do, the treatments couldn't be more different, right? In pulmonary hypertension, the focus is unloading that right heart, reducing pulmonary pressure. But in dilated cardiomyopathy, the focus is on supporting the failing left ventricle and optimizing systemic perfusion. So Natalie, thank you so much for walking through these cases with us. And thank you all for listening. This is just like the perfect reminder to take time to talk with the patient, the family, not to jump straight to a diagnosis until you've taken time to really look at all the data points and figure out the best treatment pathway. Before I let you go, Natalie, I want people to know where to find you. You also have an awesome nursing education podcast. Can you talk about it really quick? How can they find it? How can they keep in touch with you?
Awesome. Yeah. Thank you, Sarah, so much for having me. I love talking with you on these episodes. I learned something. You are so wonderful to talk to. You make me feel like you just build confidence in me and as a nurse educator and a coach. So thank you for that.
Oh, my pleasure.
You can find me at chatwithnat_RN on Instagram. And then I also have a podcast, Chat with Nurse Nat. It's a pediatric cardiac podcast. I'm on Apple, Spotify, and iHeartRadio, just added there. So check it out. And I'm new to this, so I'm getting all my tips from Sarah right now, and I'm enjoying it because these conversations are so valuable, and I want to get to know the nurses across the country. I want to hear what you guys have to say, and I love being able to have these episodes with you, so thank you.
Awesome. So I'm going to start the conversation with this. If you have a pediatric cardiac question, go find Natalie on Instagram and send her a DM. For me, it's been so helpful as a podcaster to have an Instagram because it gives me ideas for future episodes. I would say a good majority of the episodes that I do are from requests from someone messaging me a question or a case study or could you please do an episode about blah, blah, blah. I do not understand this topic. So yes, go ahead and start that conversation with Natalie. I'm sure she would love to make more podcast episodes to meet the educational curiosity of the nursing community. All right, Natalie, I think this is a great episode. Thank you again for your time today. Thank you guys for tuning in, and you guys have a great rest of your week.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.